Meanwhile, I request Dr. Arup Chakrabarti to please take the podium for the second talk, that is calculation of IOL power, what is new.
So a very good morning, friends. I'll be talking to you on calculation of IOL power, what is new. Now this field of IOL power calculation is a very dynamic, it's a very happening field. You see software or hardware upgrades coming up in existing machines, or a brand new machine with a lot of additional features that come in. There are new formulas that have come in, or existing formulas have some upgrades. And then there are some newer concepts that come in. So basically, when I looked at the literature about 6 months back when I gave a similar talk, we see that most of these anti-segment journals or the other peer-reviewed journals have carried a lot of articles. For example, JCRS in May 2024 had 2 articles. In June, American Journal had 4 articles. And when I reviewed the JCRS this January, February, March, and April, again there are 2, 3, and 6 articles. So it's a very happening field, and why is it like that? It's rightly so, because today cataract surgery is a refractive surgery, and we want to hit the bullseye at each and every time we operate, and our holy grail is plano 60 or whatever be the target refraction. You have to ensure all precautions and exercises to be taken to ensure that this kind of outcome. So where are we today? This is actually a landmark article, one of my friends, Giacomo Savini. So here, all the recent formulas were used, and the biometric indices were obtained from the sophisticated biometers. And it was seen that the post-operative, that prediction error, less than 0.5 diopter was seen in almost 90% of the patients. So this is quite a high achievement, So if we have, these are for routine patients, normal patients. I'm not talking about, short eyes or very long eyes and, complex corneal scenarios. So if we have not reached this level, that means we have a long way to go. Now, if we are already operating at this level of post-operative outcome, I mean, have we reached the limits? It is generally felt that subsequently the increments will be very, very minimal, because, biometry, perhaps we have reached a limit in terms of the axial length. Keratometry, still, things have to be sorted out, so we need some better keratometric, inputs. There are certain uncertainties about, let me tell you about the uncertainties. Say, for example, most of these IOL manufacturers, they provide IOL in increments of 0.5 diopter, like say 20 diopter, 20.5, 21, or increments of 1 diopter for the very long eyes and very short eyes. So basically, if you have calculated an IOL power which lands in between, then you're forced to use a lens which definitely is a noise, and it'll land you in outside the prediction error of 0.5 diopter. So the manufacturers have to put in exactly the power that the particular lens carries. And then the labeling tolerance, the ISO or the FDA, they have allowed certain labeling tolerance, so that, again, the manufacturer doesn't have to be very precise in putting down what exactly is the power of the lens. So because these are the things that have to be sorted out. In fact, though you're doing a very good biometry, all the precautions are being taken, but they're not, the IOL technology has to catch up with us. The other thing is the effective lens position. This is, I think, is a very important issue, because most of all the Virgin's formulas, they first calculate where the lens is going to sit, and then they recalculate what exactly is going to be the power of the intraocular lens. So this is effective lens position is important. Now I'll just show you 3 eyes, one with 11 diopter, 7 diopter, and 20 diopter. You see the postoperative position of the lens. This is a highly myopic eye. It is it is so deep. And again, a similar lens where the Rexy size has varied, and again, you see the effective lens position, it goes meaningless, So this is something that has to be sorted out. And the newer things that are coming into the picture is, the influence of angle kappa and angle alpha, and the ocular biomechanics in IOL power calculation. So literature is just waking up to these issues, and they are in the process of sorting it out. So you need to have a thought process shift. when you calculate IOL power, it is just not a one-off event in the cataract surgery patient. It spans the preoperative period, the intraoperative period, as well as the postoperative period. So before you go for the biometry, you have to ensure that the patient doesn't have ocular surface disease. If it is present, then that has to be treated till you optimize the ocular surface, then go for the biometric readings and take multiple readings so that there is, some kind of a concurrence of readings, so they are reproducible. So you please do a nil touch biometry. That means, you do the biometry before doing any of the investigations. So that is also very important. Now, sometimes, we get into the habit of dilating the pupil, for getting proper biometric results, both for ultrasonic biometry as well as, optical biometry. In fact, with IOL 700, there's a study which shows that in certain cases where the signal is not good, if you dilate, you get better signals. But then, as I mentioned earlier, the biometry should be done before the eye has been, the corneal surface has been touched, has been modified. And then, this dilatation process can alter the biometric indices. For example, there are plenty of studies which show that after dilatation, the central corneal thickness, the anterior chamber depth, lens thickness, they alter. So if we use multivariate formulas which use all these biometric parameters and use the post-dilated values, 1/4 of your patient, 25% of your patients may land up with an overt correction of 0.5 to 1 diopter. So this factor has to be definitely discussed with the patient. And sometimes we use artificial tears before the biometry, so make sure that, don't do your biometry immediately. We wait for at least 5 minutes. Now, once the eye is ready for biometry, then you go for, the actual testing. So we use optical biometer. This has become the standard of care, the gold standard. Many of us also perform a topography and eye trace to study the corneal astigmatism, the spherical aberration, and there are various other factors that are involved for advanced technology intraocular lenses. If the patient had been using contact lenses, younger patients, make sure that those contact lenses are removed for at least for a couple of weeks. The patient is on a hard contact lens. Now, as I mentioned that all of us have moved on to optical biometry, but I know that we are in a developing world and this is a very expensive equipment. So there is definitely a role for ultrasound biometry. If you are doing ultrasound biometry, do immersion scan. Don't get into the habit of, or get out of the habit of using contact applanation, because the studies have shown that with contact applanation, there is a mean average shortening of the axial length to the tune of 0.25 to 0.33 diopters. In a meta-analysis, Haigis had also shown almost a similar result, where the red bars that you see is with the IOL master, and you get a level of accuracy, post-refractive accuracy with the IOL master. Now, IOL master is not like a mantra that you put the patient on a optical biometer and you're bound to get perfect results. There are validation guidelines. So each value that is taken, measurement that is taken, we have to ensure that these values fulfill the guidelines. And if it is not fulfilling, then they have to be deleted and a fresh reading has to be taken. So this takes quite a lot of effort from the biometrist. Now, as I again repeatedly mentioning, that's the era of the optical biometers. Partial coherence interferometry came in 99, then optical low coherence reflectometry, optical low coherence interferometry in 2009, 2012. But then now in 2014, we had the IOL 700, and there are a couple of other devices which are based on swept source OCT devices. So these are quite very expensive, and they do a lot of things beyond the biometry, and but they're extremely accurate, but they're pretty expensive. So I was quite interested in seeing this article in the American Journal this January, where it is a swept source OCT device, but it has a different mode of functioning, so that the device itself will cost not more than $2,000 if it is commercialized, which is less than the cost of an ordinary A scan. So let us see how far this study progresses. Then again, the axial length that we measure, most of the swept source biometers, other biometers, they give a composite axial length. That is, you assume the refractive index, same refractive index, and take the axial length measurement. Segmented axial length, or sum of parts, where each medium is the refractive index is considered, and then it is the thickness is considered, axial length is considered, anterior chamber depth, etc. It is summed up. So it is most of the formulas, current formulas that we will be seeing here, basically are based on composite axial length, not the segmented axial length, other than maybe the Argos machine and a new software that has come up with that particular machine. Now, regarding the formulas, there has been a very great degree of chaos. The earlier classification was a generation classification, which was very chaotic. It didn't make much sense. 2014-15, Warren Hill and his team wrote a series of editorials in JCRS, where these are the classification system, which is based on method of calculating IOL power and the data used for IOL calculations. So we got used to this Barrett Universal to Hill, RBA, Olsen, Kane, EVO, Panache. But then last year, Giacomo Savini, he again classified IOL power formulas in this pattern. And it is quite intimidating, but there is a pattern in the method in the madness. I'm not going through the details, but so many formulas are coming up, and gradually we'll get to know which formula is to be used for a particular situation. I would again suggest that all of you go for online IOL calculation, because online IOL calculation will allow you to refer to all these formulas free of cost in the various websites, and then you can use any formula and then take a decision. So this does not really, you don't get confined to a particular optical biometer. So various calculators, talked about the details. The go-to calculator is the Barrett Universal 2, which is available free of cost at the APSCRS website. It is a complete suite. All your IOL power requirements are taken care of by this formula. Then again, ASCRS.org also gives you a wide variety of IOL formulas, online formulas. Again, these are all free. IOL calculators, post-op calculators, data analysis tools. The newer kids in the block now, they're doing extremely well. Kane formula, which is good for non-toric lenses. There's a keratoconus component. Then Hofford QST. Hofford Q is a formula which many of us use, but Hofford Q himself has condemned it altogether. But the people won't give it up, so he came up with Hofford QST formula. ESCRS website was the only one which was lacking a IOL formula software, IOL formula link. So this came up recently, about a year back. So for the monofocal lens, non-toric lenses, you have to just fill in the data only once in the particular fields, and then it approaches all these all these 7 formulas, and then get you a result in one printout, and it becomes very easy for you to compare the various formulas and what are the intraocular lens to be chosen. For toric lenses, there are again 4 formulas that are used. So basically, what I'd like to conclude by saying, do I have time? 3 minutes? Okay. So another thing that we need to keep in mind is many times we can take advantage of the of the post-operative refraction in the first eye that has been operated. So there are a lot of supporting articles, and I myself follow this practice. So if the first eye has been operated and there's no refractive surprise, there is interocular symmetry, there's not been any transcription error, null malposition error, then I would readjust the target refraction for the fellow eye surgery to 1/3 of the refractive error that was seen, post-operative error that was seen in the first eye. I just change the sign, and that is going to be my target refraction for that. So second eye enhancer comes inbuilt in certain in newer formulas like Pearl DGS calculator. This we also have to keep in mind that there is an increasing awareness of the gender influence on the formulas. The Barrett Universal 2 is more accurate for the males, and all the remaining formulas, they are more accurate for the females, and this difference is more commonly seen when you're dealing with extremes of the axial length or anterior chamber depth. So friends, in conclusion, in terms of IOL power calculation, please remember that you are in charge. You cannot put the blame on anybody else, optometrist or your assistant, because you have to take full control of the patient. So a proper patient workup has to be done in the preoperative period, the lines of what I have discussed here. Use appropriate measurement devices, use validated measurements, use newer formulas, and go online. And you will get access to all these formulas that I've just mentioned. Work with properly optimized lens constants, adapt to new technologies as they present. Anything that is new need not be the best that is most suitable in your practice. So first, try to see what the technology, how you can adapt to the technology, how the technology adapts to your practice, and follow that. And strive to use all available resources to their best advantage. Thank you so much for your kind attention.